So I want to start with this case. I'm going to show you guys cases that gave me a little bit of a pause and problematic, like Syed pointed out some of his cases. So this is a 67-year-old genetic female who has a 3 centimeter parotid mass, slowly grown over the course of 5 years without associated pain or facial numbness, which kind of tells you that this is a slow growing process, which is lesion or a neoplasm. There was no significant past medical history, which is very important again because salivary glands are surrounded by lymph nodes or they have lymph nodes within them. As you can see on this power, this is actually ultrasound. This is a very circumscribed mass, hypoechoic. That means it's kind of cellular. And this is the brightest part always is the muscle because that's where the ultrasound probe is. So you can see this is much more darker. So it is hypoechoic as compared to the surrounding. So the FNA was performed. And I'm going to try this. Otherwise, we'll go all the way to PowerPoint. Do you guys see the slide image? I'm sure you guys see it, but I just want to make sure that you. So this is the diff quick stain, and this was very cellular, as you can see, and so very cellular specimen, very cohesive cells. And if we go to the periphery of these cells, on the higher power, you can see that cells have a lot of cytoplasm. Some of them are plasmacytoid here. So very cellular specimen, but definitely a very single cell population. Some are binucleated. So this is definitely a neoplasm. This is not something which looks like inflammatory because this is a very clonal population of the cells. That means the cells look very similar to each other.
Excuse me, Dr. Zubair, जरा इसको full screen पे कर लीजिए अभी इस पे slide show पे ये full उस पे नहीं थे.
Let me, I think I have to, I was going to try it, see if I can. Maybe I have to share it through the application.
All right, thank you.
Does this work? Can you guys see this, or I can go back to the PowerPoint otherwise?
I mean, we can see, but it's not like, on the full screen or slideshow.
Okay. Okay, let me.
अब ठीक है जी. I think if you go back, I think it should be okay. I don't know, some distractors were coming. Yeah.
How about this now?
That's fine. Yeah, thank you.
You guys can see it, right? So you can see here, this is again very monotonous population of the cells. I do want to point out these arrangement of the cells here. So you can see again, the cells are very kind of plasmacytoid, but they're very enlarged with a very really nice chromatin pattern. And this is the highest I can go on this, but you can see there is a little bit of intranuclear inclusion in this cell. So this is definitely a neoplasm, and there is a little bit of a stroma in the middle of the cells here. The cells do have a denser cytoplasm. Again, there's a little bit of eosinophilia, so there may be a little bit of a squamous kind of change, but one has to be careful because sometimes the cells which get air dried, and if you throw alcohol pap stain on them, they will develop this kind of pinky stuff, which will be like a metachromasia. So one has to be very careful not to say that this is a squamous change. So again, these intranuclear inclusions, which kind of really helps you to say that this is definitely a myoepithelial type of a process. There's a stroma. There's no background stroma to really suggest that this, what you're dealing with, is a pleomorphic adenoma. So this was actually called at some, and it was mentioned in those days. It was actually from 2013, this case. So it was called definitely a neoplasm, and a differential was given, which was a pleomorphic adenoma versus an epimyoepithelial carcinoma or something myoepithelial type carcinoma. But again, it's definitely a neoplasm, and it looks myoepithelial. Now, this is the surgical on this case. And as you can see on this very low power, this is the parotid here. And you can see how really circumscribed this is. And one has to be careful, and this is what I was talking about in my lecture before, that these can have these lobulated borders, which is very important to notice. That doesn't mean this is invasive. Plus, as you can see, there is a little beautiful cuff of ducts and the salivary gland tissue. So this is basically a very circumscribed process. It's not an infiltrative process. Plus, when you do an FNA, one has to be careful that you will see these type of structures surrounding it with a lot of fibrosis. And this does not mean that this tumor is invading. And sometimes the ducts also get a little compressed and can mimic these tumors. So when we are now comparing with cytology, and this is very, very interesting, this is actually a pleomorphic adenoma. And this has a lot of this hyalinized stroma, as you can see here, and the cells are the similar that what we saw on cytology. So this is another version of a pleomorphic adenoma where the stroma is not that cartilaginous, it's more hyalinized stroma, and the cells are in the cords and tubules. So this can be actually can be mistaken for some other tumors, not on this side, but if you have a similar appearance in a minor salivary gland, especially in the oral cavity, you have to start thinking about the carcinomas which have hyalinization with them. So those can be polymorphous low-grade carcinomas or adenocarcinomas, now called polymorphous adenocarcinomas, or also the hyalinizing clear cell carcinomas because they can have these band of hyalinization. But this is the parotid gland, and this is a very circumscribed tumor, not infiltrative. So this is actually another version of a pleomorphic adenoma. Okay, so is this works, or I can go back to the PowerPoint? Please just let me know. You guys can see the slides? You can. Okay, good. Okay, so next case that I'm going to show you, which case actually gave me a bit of a pause. And this is a very interesting case. This was a 78-year-old female who had a history of breast carcinoma. And she had this mass, which was actually in the parotid gland. And it was very, on the radiology, it was thought that this is actually an infiltrative mass. So this is actually a difficult slide from it. And the radiologist was very worried about this. So you can see that the smear here, and just going to show you some of the. Now, what was very interesting was there was a lot of fat that came up in this smear, and it didn't look as cellular as you saw in the first case. Now, when I go higher on it, I noticed that there are some multinucleated cells here, and there is a little bit of inflammatory cells that are going through this. Now, what is also interesting is that within these multinucleated cells, you see these really kind of holes within it. So there is something going on here. And this is very infiltrative kind of process, which looks here, but it's all in this fat. There's nothing that I can point out to say that these look like tumor cells. Now, when you look at the cells here in the bottom of it, you notice these cells have a lot of voluminous cytoplasm. And this just looks like a bigger version of a histiocyte. These do not look like tumor cells. So this looks like a very kind of repetitive process, a lot of grungy material in the background. And what I want to point out that this is stuff which we will see on the pap stain slides also. So this was on site. I was on site and I noticed this type of stuff here. And to me, this was almost reminded me of a sharp crystalline type material because it has very sharp cytoplasmic borders to it. There's no cells in it. So this looks like some kind of a material in the background. Now, this putting the histiocytes together, plus a lot of fat that you're getting, this grunginess to the cells in the background, and even those sharper stuff within those multinucleated cells, I thought that this most likely represents a non-neoplastic kind of process. But the radiologist was insistent that this looks like to them a malignancy which is diffusely infiltrating throughout the salivary gland. So I'm just going to go to the PAP now slides. And this is the PAP stain slides. And the way this was smearing was also very funny. It was not smearing like what you can see. I just want to go back to the difficult again, just show you this one thing that I noticed on site. And here you can see that some of this stuff here, this is a collection of histiocytes. And this was very interesting because I'm seeing these multinucleated cells plus these kind of epithelioid cells with histiocytic stuff. This almost looked like a granulomatous process. Now it kind of makes sense that you have those crystalline matter and then you have this granulomatous process. So I went actually to the patient where they were getting biopsied and asked them what happens to this mass. And she pointed out that this waxes and wanes. Sometimes this mass is bigger, and sometimes it gets smaller. When it's bigger, it's kind of painful, and it takes a couple of days, and it kind of relieves itself. So this is very typical of what you can see in the blocked ducts. And now you can see here, this is the Pap stain slide. And I just want to point out to you guys this. Let's see if this will cooperate with me. Again, those really histiocytic type cells, a lot of fat in the background. And again, you notice that very crystalline material with multinucleated giant cells in the middle. And the crystals are very much more, you can see here, really, you can see a lot of these crystals. So putting together histiocytes, the history of this painful enlargement, which goes down long time, even if the radiology is very suspicious of a malignant process, what we have on cytology is something which is non-neoplastic and inflammatory. Now, this condition has been described in the literature, and it's called crystalloid granulomas of the salivary gland. Where the ducts get blocked, the most common gland that is affected is the parotid gland. The ducts get blocked with this crystalline type material. There's something happens to the pH. These are amylase crystals, and then the duct becomes inflamed. The worst kind, you will see some squamous cells, and they can look really horrible. So I call this the crystalline granuloma. Even send the literature to the surgeons, but sometimes surgeons think they know more than the pathologist. I'm sorry if there's any surgeons in the group. So they still went back and said, radiology, I'm okay, Zubair, with your diagnosis, but I'm going to go back and take it out because I'm very afraid that this is going to be a malignancy. So this is, so I was on the sign out, and I got this on the sign out also. And as you can see, there is the parotid stuff here in the background, and there is this material, very hyalinized, and there is kind of a lymphocytic type infiltrate. Now, again, this is very confined. There's a little bit of infiltration on the back, on the top, but this is most of the stuff is inflammatory stuff. And you can see here, there are these ducts which have undergone squamous metaplasia, and thank God I didn't get those on site. And you can see here, a lot of histiocytic reaction, it is in here. And those are the same histiocytes we got on stuff. And this also has crystalline type material embedded in it. So this is actually an inflammatory process. And here is, again, this is nothing but inflammation. Now, on surgical pathology, when you see a lot of inflammation and you see some kind of a sclerosis, and even if you're thinking of a non-neoplastic process like what I am showing you, you have to make sure that you rule out the IgG4 disease, which also affects the salivary glands, in which you'll get a lot of hyalinization and you will get a lot of plasma cells infiltrating through it. You see that in pancreas, you see this in the thyroid. It's a multi-system disorder. So one has to be careful. But in this case, it makes sense that this was a case of a hyalinized granuloma. So I think this is actually a very interesting case that you're going to sometimes will get. And I have seen actually now, since I'm thinking about it more, I've seen multiple cases of these. And you can now imagine that if the FNA needle goes in the areas of this squamous, here the multinucleated giant cells, and here's the crystalline material in these multinucleated cells, that how these can really be mistaken for a malignancy on the cytology. Okay? So I thought this was a very interesting case to kind of share with you guys. So now let me show you this case. This on radiology, this is actually a woman who has a history of breast carcinoma also. She was being scanned for it, and they found this parotid mass, which looked infiltrative. So the radiology and CT scan were both suggestive of malignancy. And now this is a difficult stain. And let me go on high power. Again, these are all my cases, so I don't want to. I always promise my colleagues that if I'm going to show their cases, I'm going to have their permission for this. So you can see here, there is a lot of cells in the background. They're kind of overlapping and crowding on the top. There may be a little bit of kind of what can be like a tumor necrosis. Now, some of these cells here do have little foamy cytoplasm. And this does look like tumor. It does not have a lot of inflammation in the background. And what I want to point out is this area where you start to see this kind of vacuoles among the cells. So let me go to the thinner parts of the smear to kind of show you. Here there are cells which are elongated, some foamy looking cells, some denser looking again, but I want to show you these tiny vacuoles that I'm pointing out here, and these will be better seen when I move to the cytology. And here is the cell which almost looks like a kind of a signet looking cell. So this is actually looks like a neoplasm. The way it's coming out with the foam cells, you have to think of malignancies. And when you start thinking of malignancies, you have to think of mucoap, some kind of adenocarcinoma. Always think of metastasis. And then with those signety looking cells, you have to think of something which is like a secretory carcinoma head, something which looks like a gland type material here. So let me go to which I think is the best. Now, these smears, I know you guys all make great smears, but these smears were taught to me by Dr. Gupta, and Syed knows he's at Hopkins, and he was trained by Dr. Arizon, and both Dr. Gupta and Arizon were students of Dr. Frost. And in those days, it was really mattered that the cytology preparations should be, and I was always told by Dr. Gupta that your diagnosis is as good as your cytology preparation. So one has to be very careful when you're making these smears. And I'm very lucky in my institution that we have both smears and thin prep and cell block. So I think you really learn a lot from smears. Now this is the Pap stain slide on it, and which I think really gives to the diagnosis and also what else you're going to do on this case. So again, these necrotic stuff in the background, which is kind of has that histiocytic appearance, but you do see cells here. Let me see how high. So there you can see these cells, which look really kind of have this secretory look to them. There's kind of histiocytic cells, but I want to point out these cells with a very, very tiny vacuoles in them. So this is actually very important. Now, in this case, the patient does have history of breast carcinoma. So you have to be careful that you are not dealing with a metastasis because she had history of a ductal-lobular kind of differentiation in her breast cancer. So again, this really beautiful secretory stuff in these cells. So your differential will be, is this a mucoep? But in mucoep, you really do not see really those beautiful secretory stuff in the cytoplasm. You have to think of metastasis, some kind of adenocarcinomas, because there is still a group of adenocarcinomas, NOS, and you have to think of secretory carcinoma. And here again, I want to point out this beautiful kind of a secretory thing, and almost looks like a gland formation on this case. So I basically saved the specimen, sent it for NGS, and also had a fish on one of the diff-quick smears, and it turned out to be an ETV6 translocation. And so this was actually a secretory carcinoma. And the surgery was done along with lymph node dissection. And this is actually the searchpad slide. And you can see how this tumor is so big. The tumors in the parotid can have a cuff of lymphocytes around it. This does not mean that that's a metastasis to a lymph node. It can happen in acinic, mucoep, secretory, and even other carcinomas. But you can see this is the tumor, and this is the normal salivary gland here. And when you look at this tumor, it does have kind of two parts to it. One almost kind of reminds you of thyroid, which is like a gland formation. But here is the the main tumor mass here. And as you can see here, this tumor does have kind of a secretory look to it. There are these kind of ducts, and if this was in the breast, it will kind of mimic the secretory carcinoma or even a ductal carcinoma. And this is what you're getting from. You're getting these cells with a lot of vacuoles in them, and you can see this mucinous material in the background. These are S100 positive, they're GATA3 positive, and they're also GCDFP positive, and they're positive for mammoglobin. So you have to really pay attention to these tumors because they can mimic, and the diagnosis can be very difficult because they will have a same immunohistochemical profile as the breast tumors. And they sometimes can be positive even for receptors. My cases have not been, but the other people have said the same. So, so you can see how the tumor also mimics mucoepidermoid carcinoma, but this secretory nature to it, those microvacuoles within the cytoplasm, and this type of a mucinous material is really very typical of these tumors. So this tumor, once you see it a lot because these tumors initially were misdiagnosed as either actinic, secretory type, or even mucoepidermoid carcinoma. Okay, so I'm going to stop sharing this, and I'm going to go back to my, I had just had a case which I want to share with you because I think it's important to show you this case, which really is. So she's a 32-year-old genetic female. She had a history of multiple sinus infections. She was found to have a firm, less than 2 centimeter mass on clinical exam. Her radiologic studies confirmed a 1.7 centimeter mass in the left parotid gland. And then she had ultrasound and CT scan done. They both showed a solid mass, which they thought is a tumor. It did have a sharp borders, so they were really not worried about a malignancy or a high-grade malignancy with infiltration into the surrounding gland. It was hypoco, and they said there's a mild irregularity, so which is still for a low-risk malignancy. So I do not have radiology on this because the radiology was done outside. I tried to get it, but I couldn't get it in time. So this was, I was on site, and this was actually the FNA, and I'm showing you the best place. So I could only make 2 smears. So you can see here, there is a lot of kind of mucinous material. There may be some cells kind of embedded in it. But here you can see that, again, this kind of vacuolated, and notice the close association of the fat with these. Now, when the patients are obese or in the older age group, you may get a lot of fat on your smears. Having fat with the cells does not always mean that this is an infiltrative process. What it means sometimes that the process is actually lobulated. So you have a lobulated appearance of these, whatever the lesion is, and there's a fat which is intervening in it. So that kind of narrows your differential what you're looking at. What it does for me and what it should do for you, that you should bring in some non-neoplastic or low risk or benign tumors in the differentials, because those tend to be lobulated and with pushing borders. It does have this mucinous type material in these groups, so I think which is really puts into differential, are we dealing with something which has kind of a dissecting mucin, or this has a process where there is a duct with a mucinous metaplasia? So those things should come to mind. Now, wherever there were cells here, and this is again a high power of this, you can see the cells forming these kind of structures. They have this very foamy cells, which may still be the fat cells. Is there a mucin or not? And then again here, this is one of the groups. So you can see that this looks like a little clonal type process because all the cells look similar. They're trying to form these gland-like structures, and there is really like a mild nuclear pleomorphism, not a lot, and there's no necrosis in the background. So that will be kind of approach. So you start to think about a low-risk neoplasm, but also keep benign conditions in the differential. Now, this is the Pap stain slides. This was very interesting because whatever came out was very cohesive. There was no falling apart. Remember, malignant tumors by nature fall apart. So you're going to get a lot of single cells in the background. But here, this process was very cohesive. There were no ducts. So this is definitely a monotonous proliferation. So this is not something that we're dealing with a normal salivary gland or just kind of hyped up salivary gland process. Again, the cells have a little bit of a denser cytoplasm, so they have a little bit of an oncocytic change to look to them. They're trying to form these rounder, larger structure. So they're trying to keep this kind of acinar kind of grouping, but these are little still larger. But again, same proliferation on the cells. And again, this kind of a mucinous kind of material in the background. So that is actually was very interesting in this case. Same type of stuff, but just I'm showing you more of it. Some cells do have this kind of voluminous cytoplasm. So now you have to start thinking of, are you dealing with a low-grade malignancy? And if you're dealing with a low-grade malignancy, you have to think about mucoepidermoid carcinoma, which comes on the top because it has this kind of epidermoid intermediate type appearance. You have cells with a vacuolated cytoplasm. So this case was called as suspicious for malignancy. I really, at this point, did not know about this lesion. I have not seen it. I have heard it. So once you have not, if you have not seen it, you can go through books and you can read the books, but all the articles. But if you have really not seen it, sometimes it doesn't hit your radar. So I said, this looks like a malignant process or a neoplastic process. And I gave a differential, and my differential weighed more towards the neoplasm. And that differential included a low-grade mucoepidermoid carcinoma in the differential. And the surgeon was, that's fine, and we are going to basically do a superficial parotidectomy and take this out. So this is, what we talked about, that you have mucinous tissue, you have adipose tissue integration, mucinous neoplasm, and you also have to think about something like an oncocytoid neoplasm, but definitely not Wharton or not kind of acinic cell. So the surgeon did a superficial parotidectomy, and I want to show you, and the people who, among you who do breast pathology, if this was in the breast, they will have a diagnosis by just looking at the low power. So you can see the rim of a parotid tissue. This is really a circumscribed lesion with some of these ducts which are kind of dilated, and then some of them are compressed. Again, look at the lobular appearance of this process. This is very lobulated. And when a process is lobulated in the salivary gland thing, you always think more of a benign kind of a process than a malignant process because it's not very infiltrative. Now, this is a high power. And if you do breast pathology, it does have that sclerosing adenosis type look, or kind of almost like, for me, sometimes looks almost like hematomatous. And you can see here, these are the ducts which I was getting on there, and then they are lined by these cells. Some of them have foamy cells. That sclerosis in the background. And let me go on a high power to show you these really trapped ducts within this sclerosis. There's a little bit of an inflammatory infiltrate. Some of these have this like a mucinous type material, which we saw on the cytology. And really these clearoid cells. Now, some of the cells are oncocytic from the duct, and this is what was giving us that cells with the denser cytoplasm. And some of these ducts even almost have what I call it like a dual population, like outside clear cells, like a myoepithelial cell, and inside the ductular cells. So this is a very confined process, low risk, does look either inflammatory or neoplasm. So this is what is called as sclerosing polycystic adenoma, which kind of mimics sclerosing adenosis. And I think once you know it, they say it is a rare process, but I'm sure you're going to see it at least once or twice in your practice. Why I'm showing you a rare case? Because I think it is very important. Once it's a high-grade tumor, I mean, I don't think we need a residency. And anybody can look at the slide and say, this looks bad. But these really borderline processes, these low-grade processes or low-risk malignancies are the one which have a lot of overlapping features and can cause really problematic. And that same applies to cytology and surgical pathology. Initially, when this was described, it was given the term as polycystic adenosis, which was in 1996 by Dr. Smith and O'Clair and Slater. So they thought that this is actually similar, that looks to in the breast as a sclerosing adenosis. It is more common in genetic females. And it was really initially was described as reactive things. But now we know that these are clonal tumors. They actually can have mutations in P10, HRS, but most commonly P13K. So this is definitely a clonal neoplasm. There has been cases, one which I don't believe, of a malignant polycystic adenoma or polycystic carcinoma, but I think it was more of an underdiagnosis or wrong diagnosis. But there has been recurrences because it's very sometimes hard to go around them and really shell them out. But they are treated by surgical excision and they have a good prognosis. There's a reference in 2023 Head and Neck Journal. There's an amazing systematic review of this case that has been described. At present, I think there's about 70 cases in the literature. But I think once you start looking at this, once you know the morphology and happens, you will. But I promise you will see at least one or two in your practice if you're seeing a lot of salivary gland pathology. So I think this is very important to know about these cases. So this is another case, and I have given you some of these cases that I sent Dr. Hussain the link. So I hope you got that link and you can actually preview these cases online. So this is how I got this case. And I apologize to Syed. I cannot finish a slide conference without showing some of the thyroid or its vicinity type of cases. So I'm sure he has amazing cases. I just want to show you something which is in this region can be kind of difficult. So this is a 54-year-old genetic female. She had a 1 centimeter. This is the history we got. Left thyroid bed mass. The history of thyroid carcinomas for carcinoma, which was papillary thyroid carcinoma in 2011. And the slides were actually not reviewed at that time. So here is the lesion, and this is the left thyroid bed. I did put the Doppler, I showed you the Doppler one, and the Doppler looks at the vascular flow. So this is actually the lesion here. Again, the probe is here, and this is the sternocleidomastoid muscle. And you can see here, this is a lesion which has some vascularity to it. And the running diagnosis was that this is a recurrence of its papillary thyroid carcinoma. I did not have looked at the slide. So if the papillary carcinoma was confined to the thyroid gland without extrathyroidal extension, it will be very hard for it to have a recurrence in the thyroid bed. But, never say never. We have all seen these cases which can be funny. So on the virtual slide that I've given you, you will see this case is listed as case number 1. And you can see here, there is definitely cells in here. But even on DIFCOI, all of us have seen a lot of papillary thyroid carcinoma. This does not look like papillary carcinoma. So that's definitely out. What it does look like, cells have different sizes, but they have really round, beautiful nuclei. There's a nuclear pleomorphism, but it's kind of within the spectrum of the most smaller to the larger cells. What also is very important to notice is the cells have vacuoles in the cytoplasm. There is a cytoplasm here, but even if I can tell you that there is a little blebs on the edges of it, which have been described in the thyroid follicular cells, or blebs of thyroglobulin, or what is called as fire flare cells. But these cells may be oncocytic cells or maybe not be thyroid cells. And you can see here, again, that same random nuclear enlargement. Now, which lesions do that in the thyroid will be oncocytic cells. But this patient had a papillary thyroid carcinoma, which was called as classic. I had the report in hand. No chronic lymphocytic thyroiditis, but anything can happen because total thyroidectomy doesn't mean they are not leaving any tissue outside. Other thing to notice is when they're mucking around in the neck, sometimes you can get parathyroids kind of embedded in the thyroid bag, and they can look like this because this does have vacuoles in the cytoplasm. But it's still, the jury was still out because I was like, this does not. So what I did, took a small portion of the aspirate and did send for thyroglobulin assessment. And the patient's thyroglobulin was basically undetectable, and she was on thyroxine. So I did send for thyroglobulin, and it came very low. Basically, what was the serum? This was not high, because if this was a follicular-derived thyroid tissue, it would have caused, a high levels of thyroglobulin. So this was, I said, this definitely looks like a neoplasm because very monotonous tissue, but I cannot go further than this on site. And again, just showing you. Other thing to note is sometimes medullary carcinomas can have these small vacuoles in the cytoplasm, which is calcitonin, but this patient does not have history of medullary thyroid carcinoma. And when you start thinking of medullary thyroid carcinoma-like cells or cells in that kind of area, you have to start kind of, really get more information on this patient. Now, this is actually the best I can show you from the thin prep. The PAP did not have much. Again, that really anisonucleosis in some of the cells, but the cells really keeping those round, beautiful nuclei and even chromatin pattern. So my thing was, this was in light of the history, as we discussed, it's not papillary thyroid carcinoma. There's no high-grade features. Other diagnoses, medullary thyroid carcinoma versus metastasis, can also be an oncocytic neoplasm. So I called the clinician and I said, do you have any more history? And he said, well, no, this patient was referred to me by an endocrinologist who works in the community setting. So I called the endocrinologist. The patient has a history of paraganglioma on the neck, and this patient is from a progeny of SDHB deficient tumors, which is very important because they can get very aggressive tumors. And this paraganglioma was removed from the neck. So this was the surgical excision on the neck that was done. And as you can see, this is definitely a neoplasm, which has some sclerosis and really invasive kind of borders here and infiltrative. And on high power, you can see these are the same cells we were saying. The one word here of, if you consider it as a diagnostic pearl, paragangliomas can have vacuolated cytoplasm. They not always have to have that denser or less cytoplasm. They can have enormous amount of cytoplasm, especially the paragangliomas that happen in the head and neck areas. So one has to keep those in mind. They just all of them do not look like carcinoid tumors. There is again that random nuclear enlargement and that sclerosis. So this was a recurrence of her paraganglioma, which was priorly resected. And this is just to show you that, again, that voluminous clearoid cytoplasm. So when you get something which is monotonous on the spectrum, but that random nuclear enlargement, think of paraganglioma, because this is the tumor we really don't think about too much when we're dealing with, because we're always thinking of, especially when it's in the odd locations and not in the carotid sheath and stuff. And as you can see here, this was beautifully positive for chromogranin, and I did other stains on it also. Now, head and neck paragangliomas, as you all know, especially in SDHB deficient patient, that these are basically malignant tumors. This is an adrenal field, which is also a paraganglioma. You have to do stains when you get the initial case. You have to do a whole battery of stain. My favorite stain is also a reticulin stain, which I'm sure you have it available also, because what it tells you, the nest size of these tumors, because you have to score these tumors on surgical pathology. I do SDHB because I want to point out that some of these patients may not have that diagnosis to see if they are retained or deficient, because if they're deficient, then the family needs to be tested. On the molecular level and how you score them, you use the gap or the PASS score. I use both, but the gap is much more important on SearchPath because that actually puts in a lot that also applies to head and neck paraganglioma. The molecularly, they are very diverse tumors. There are 4 pathways in these tumors. The one in the head and neck, you have to think about the tumors that arise through the HRAS pathway or SDHB. And these are the tumors you have to worry about because they are familiar. You can do actually immunohistochemistry, simple immunohistochemistry, to really figure out which kind of sequence these tumors belong to. But SDHB is much more important. So I think this is something which mimics other tumors, again in the neuroendocrine range. but to show you that some of these paragangliomas and head and neck paragangliomas specifically are by definition malignant until proven otherwise. So one has to be very careful when you're dealing in that side. So I thought this was something which is really has a lot of overlapping features. So I think I still have good 15 minutes. Please give me a shout out if I'm over time. Okay. So this was a patient which has a 58-year-old man with a 3.6 centimeter left parotid gland mass with pain and numbness. And as you can see here, this again, I think this is probably the same clip I should know this. So you can see here, again, this has a very infiltrated border. So this is a good correlation with what you're going to see on cytology. So you have this tumor which has really not smooth borders. Again, this is the probe. This is the parotid gland as a really brighter look. And you can see how this is more of an invasive piece. So by radiology, this already is a malignant tumor. I've seen one version of case to you. And again, this is a very beautiful case here. You can see here, again, those beautiful small secretory vacuoles. So we're dealing with the same stuff we saw. And now in this case, what I noticed also that some of these cells have kind of spindle nuclei. So this type of tumor can be very heterogeneous. And this is what the problem is with the salivary gland tumors. This is a cell block, and I always, when I have funny morphology, I always try to get extra passes, if you can, to get a cell block. And on the cell block, you can see here that you have this beautiful papillary kind of grouping of these kind of micropapillary formation, plus again, those secretory kind of signet looking cells. So, so one has to really look for those cells, and I apologize. And so for me, that was very important. So the thoughts are, this is definitely malignant. What I'm seeing on cytology and what is by radiology, the differential will be tumors with clear cells, tumors with oncocytic cells. So you have to think of actinic. You also have to think of mucoepidermoid carcinomas because they can be oncocytic in nature. You also have to think of secretory carcinoma. So definitely that cell block helps. And this is a GATA3 stain on the cell block. And this is a very limited amount cellularity cell block. And it was also positive for S100 and hemoglobin. And I submitted one of the cell block slides for ETV and TRAC3 translocation. It came back positive. So this is another case of secretory carcinoma, which is showing you those kind of papillary formation. This is cystic tumor, and I showed you this in my lecture also. It has these beautiful papillae. So when you're dealing with papillary tumors, you have to think about tumors which form. So the intraductal process can be papillary. Secretory carcinoma can have papillary formation, as well as actinic cell carcinoma. And again, parotid tumors or salivary gland tumors have cup of lymphocytes. That doesn't mean they are in the lymph node. I always keep on telling this to my fellows and residents because they always think this is metastasis. So you can see here the tumor which is infiltrating, and it really on the high power. This has the same features what we saw on that cell block. So cytology is actually gold in these cases, as long as you really try to get as much material as possible. And I think you can, by even doing those simple immunohistochemistry, you can really at least guide the clinician what you're dealing with. And this really correlates very well with what we saw. So this is the end of my cases, but I just want to go back and do one more case for you. If I have time. Yeah, okay, good, excellent. Are you guys okay with one more case, or you want to take a break? Okay, so I'm going to show you guys one more case, which is actually one of my favorite cases. If I can, okay, here it is. So this case was a patient who has this parotid gland mass, you know, and it looked kind of circumscribed, very small. That was so basically it was less than 2 centimeters, one actually plus some centimeters. I apologize, I do not have exactly So this is the quick slide. So even from that small tumor, this was an ultrasound guided FNA. As you can see, there are a lot of cells in this. Let me just make sure that I am sure. Okay, good, excellent. So what was very interesting in this case was, and let me go on high power, that most of these cells are oncocytic cells. Some of these cells, and I gave you this whole big lecture about cells, oncocytic and plasmacytoid cells. So I'm basically going to debunk what I talked about. And I think that's what makes our life more interesting. I hope Syed and all of you guys agree with me. So that kind of has a monotonous population, definitely a neoplasm. And you can see some of their cells actually have more voluminous cytoplasm, which is very typical of oncocytic. Kind of nondescript groups. Again, there is fat, maybe some lymphocytes in the background because this was very gentle smearing. Late Dr. Gupta, even he has passed, he kind of speaks to me a lot when I'm making these smears because nothing freaky, but I always think he's going to like slap me if I smear too hard. So I always tell my fellows and residents to please be gentle with these very precious and limited material. So it's basically the same process. What you're seeing is as oncocytic cells here. And now let me just go. So this is the pap stain on this. So here, this is, you can see this is the pap stain. And again, making a beautiful smear is not to have the cells scattered throughout the smear. If you are gentle, you can really make these beautiful concentrated smears where the cells are actually in one area. So you're not going through the whole smear and spending time looking at the cells. Now you can see here that the same theme comes through. What you're looking at, these very oncocytic cells. And let me see if I can, that's the highest I'm going to go here. And really, it looks like an oncocytic cytoplasm, a neoplasm. This is where the differential comes in of the oncocytic or oncocytoid tumors. You have to think of oncocytomas, oncocytic carcinomas are no longer allowed in the new WHO because they think there are other tumors, carcinomas with oncocytic. So I do not use now the term oncocytic carcinoma, but you have to think about the cellularity and the stuff. It's definitely a neoplasm. Now there's a little bit here that I want to point out that some of these cells do have kind of clear cytoplasm and kind of foamy cytoplasm, which are kind of hiding among these oncocytic cells. And when you see this, you have to think about secretory carcinomas, acinar cells. You also have to think about oncocytic mucoepidermoid carcinoma, which can have a main population of oncocytic cells, plus these little secretory cells. So this is something one has to really keep in mind that, you know, this can look like this. So now this was, so I called it oncocytic neoplasm, and I said, gave the differential, and my differential, the top differentials included all the carcinomas, which was oncocytic mucoep, acinic cell, and then at the bottom was secretory, which I don't think this was, and like an oncocytoma, which I also don't think this is an oncocytoma. I got a call from the clinician because he really said, I want to do a one-step operation. I don't know, and if there's a lymph nodes, I need to take the lymph nodes out. But this is a very small lesion. So what I did actually, one of the diff-quit stain smears, I restained it and sent it for MAML2. And this came back as MAML2 positive. So this was definitely a mucoepidermoid carcinoma. I did not have a cell block on this case. And this is actually the search path on this case. And as you can see here, this is a very circumscribed tumor. It's not that small. It's actually a larger tumor than was noticed on the radiology. Again here, very dense tumor here, but you can see here how oncocytic this tumor is. And let me just take you to one of the areas here. So this tumor has many more oncocytic cells than you see normally in a mucoepidermoid carcinoma. And you can see all those. So this was actually more of a denser tumor. So this was more on the intermediate grade side. There's no necrosis. But what I want to show you is this cytology of these tumors. So oncocytic change can occur in mucoepidermoid carcinomas. And sometimes these tumors are associated with a lot of lymphocytes and can actually mimic Wharton tumor on cytology and even on search pad. So you can see how oncocytic this tumor is in here. And this is actually, I was able to, yeah, great, excellent. I got it. So let me show you. I think I'm getting more excited about these cases than you guys are probably. But look at these. Look at the mucocarbon stain. Simple stain, and it really stains. You want to see the intracytoplasmic mucin, not just the mucin in there. So you can see those mucocytes. But look at the less amount of those mucocytes in this tumor. It's basically a very dense oncocytic tumor. So I think this is something one has to also think about when you get these oncocytic tumors, that how these tumors can be very oncocytoid and can mimic other tumors. So I think this is where I'm going to stop sharing. I think we have talked enough about salivary gland to ad nauseum, and I will share some cases tomorrow, and you can again see how little that is. So I think this is something very important to keep in mind when you're dealing. And I mean, this is a very fascinating area, but at the same time, it's kind of a headache producing because there's so much overlap in these tumors. So thank you so much for giving me time to and indulging me with these on this session.